All right, everyone, it's 12:40, so we're going to go ahead and get started with the second half of the general session. I'd like to introduce our next speaker. Kate Castro is a nurse consultant and program director in the Office of the Associate Director of the Healthcare Delivery Research Program. She's also an NCORP presenter and strong supporter of this workshop and the SWOG CCDR work and the NCORP sites contribute to. She's going to discuss NCORP cancer care delivery research and the fall kickoff. Thank you.
Thank you so much, Sam, and thank you always to Sam and Monica for inviting me to give a brief updates on the behalf of the cancer care delivery team back at NCI. Quick question for everyone in the room. How many of you are new to NCORP, new to kind of your roles here? Got a couple of people. Oh, yeah, a number of people. Excellent. So when Monica and I were communicating last week, I guess, talking about, the opportunities we have here, we really wanted to make sure that we were welcoming everybody who is new to the work and making sure that you're feeling like you can ask any questions you have of any of us. And on behalf of the NCI, I'd also like to acknowledge my colleagues who are here with me today, which I probably don't have to introduce Marge to anybody, but Marge Good, right here in the second row, and also Bernard Parker. So Marge and Bernard and I are always here for any questions you might have on behalf of the NCI team. So I'd like to start by thanking everyone who attended the NCORP annual meeting, which was held the end of August. That seems just like yesterday, but it was actually over a month ago in Bethesda, Maryland. And hopefully a lot of you either were able to attend in person or listen virtually to the sessions that were held. It was a 3-day meeting, with the first day being an administrator session, and then the next day and a half being the main meeting that we had. And we had over 200 attendees in person and almost that many online as well. And you see here on the left side of the screen, you see a picture of the cancer care delivery breakout session that we had on Friday morning, which was incredibly well attended and a lot of really robust discussion. And one of the conversations that came out of that was there are people who are new to this work and would like to know more about how others are doing the work. So we did get a really nice group of people's names and contact information who are interested in helping. Anyone who would like to hear more about how another site might be doing their cancer care delivery work. So if anybody has an interest, is new to this, just wants a refresher, or says, I'm kind of stuck on a protocol and I'd love to hear about another site that's doing it, please reach out to me and let me know, and I would be happy to connect you with some of the resources that were identified for us at the session. Sarah Behringer, my colleague and project director for cancer care delivery, and I are happy to make those connections. And then I would like to always acknowledge our highest awards. This is like our Grammys for the NCORP annual meeting. And the Dorothy Coleman Outstanding Administrator Award this year went to Peggy Wisher from the Heartland NCORP. And the Harry Hines Award went to Dr. Jeff Berenberg, who was right there a moment ago, and now he has disappeared just like that. But really a pleasure to have both of them receive these awards this year and acknowledge the incredible work that they've done for years and years within the NCORP. To give you some updates on our cancer care delivery research portfolio, we wanted to start by stepping back a little bit and just grounding everybody in the type of work that we do. And sometimes I hear people say cancer care delivery research is difficult. And I don't want to say it's difficult. I want to say it's different. And it is a different type of research, but it can be incredibly rewarding and really enjoyable to do. And it answers some very, very important questions for us. We really are the group that takes the evidence that is already out there or has been determined to have efficacy and looking at how do we get this into the care delivery system? How do we get something to be sustainable in that care delivery system? So with that, we're looking at a variety of different things. We're not only looking at patients and sometimes their caregivers or family members, but we also may be really doing interventions with the clinicians themselves. So that could be physicians, advanced practice providers such as physician assistants or nurse practitioners. It could be a pharmacist, an oncology nurse, a social worker. There's just a variety of different clinicians that might be the focus of that targeted intervention and not the patients being the focus at all. We also might have a focus on the organization itself. We do have some studies that do not have any human subjects recruited to them at all. They are focused on the complete organizational level. So we want to look at things that we can modify or change within that care delivery system and trying to be as pragmatic as possible. And I know we hear the word pragmatic over and over again, but in the care delivery system, we know that if you've seen one NCORP, you've seen one NCORP as far as how a clinic works or how a care delivery system might work. So these are really the goals of what we do. And I do have a link there on the bottom. That's to our website where we have actually a nice video that's about maybe 5 minutes long that gives you an overview of cancer care delivery research for anyone who might want a little bit more information. Our work is also very well grounded to the National Cancer Plan. So the National Cancer Plan was unveiled last spring by our director, Dr. Monica Bertnoli. And all of the work that we do within NCORP really ties very well to this National Cancer Plan. I've highlighted three key items here that our team really thinks resonate with us in the care delivery space. So eliminating inequities, looking at that optimal care delivery approach, and also making sure that every person is engaged. So a lot of times when we're doing our intervention and it's at the practice level or the clinic level, every patient who walks in that door is touched by that intervention because it's actually the practice that's randomized to the intervention and not the patient itself walking in the door. Also want to say that on the right-hand side here, you see that everyone has a role. And I think a lot of times when we hear these big, ideas unveiled, we think, okay, yeah, well, I'm a person here enrolling patients on a study, so this doesn't relate to me. Well, you can see here, it does relate to all of us, and everyone has a very, very critical role in the work that we do. The healthcare professionals are really the key behind all of this. So our cancer care delivery research portfolio, which we came into being when NCORP came into being in 2014. So we are 9 years old at the present time for a research area within the community network. And we have 24 protocols that are currently approved within the protocol or within the portfolio. And you can see here just a variety of the care delivery gaps that are addressed. And I'm going to highlight some of them today, namely the SWOG studies and thinking about some of these key areas which we're looking at, again, guideline adherence, health expenditures, financial toxicities, things such as that. So as a reminder, cancer care delivery research is part of NCORP. It is funded by what we call Cancer Care Delivery Research CCDR restricted funds in the NCORP grants that your organizations receive. And so in order to participate in a CCDR study, you must be affiliated or be a sub-affiliate with an NCORP. How do you know if it's a CCDR study? It is designated as having a CD at the end of its numbering convention. So the example is S2108 CD is a cancer care delivery study. And this is a very clear indication for you and your team members that this is a study that you can use your CCDR restricted funds for. Research-based committees may be broader than that. So I'm going to use the SWOG CCDR committee, which is a terrific committee, as an example. So that committee, when you go to the session tomorrow, you will hear about numerous different studies, some of which will have a CD at the end of them, others will not. So S1703 originated in the Cancer Care Delivery Research Committee. It is not a cancer care delivery designated study. It's a cancer prevention and control NCORP study. And again, it doesn't have that CD at the end of the name. So just some of our little nuances of how we make the differentiation. So all the studies that I'm going to talk about today are NCORP cancer care delivery specific studies. So we have two SWOG studies that I wanted to highlight here, and Dr. Hirschman mentioned both of them earlier when she opened our session today. The first one is the S2108 CD, which we know is the Educational Genomic Tumor Board study. This study has accrued incredibly well. The rate of this accrual is the top of any of our cancer care delivery studies we've had so far. And when I checked in the other day, it had 620 patients already registered to it with 126 physicians. So the non-patients in this, or I'm sorry, 108. The non-patients here are specifically physicians, and then 65 practices that have opened the study. So this is an example of a cluster randomized study or a practice randomized study. So the intervention's being done at the practice, and every patient that walks into that practice has the opportunity to be touched by that intervention. And they're grouped into what we call recruitment centers, and SWOG has done a very nice job of defining in the protocol what creates a recruitment center. And so that's how the patients are then treated at recruitment centers that are the level of the randomization. This again is a multi-level study. So we're collecting data about patients and the treatments that the patients have received. We're also collecting data from the clinicians that are participating in these genomic tumor boards. So again, a little bit of a different flavor of a type of study for you. The next one is the S1912 CD, which is known as the credit study. This is looking at financial hardship. And I'm very pleased to say that this study, as Dr. Hirschman said, had some amendments, major amendments based on the feedback that you all gave. And I'm pleased to say this study is moving very nicely with accrual now. So it was originally where the spouse was a required eligibility. You had to have a dyad, a patient and their spouse agreeing to consent to the study. And the spouse or the partner participation is now voluntary. And I will agree that there is a large number of partners who have still agreed. You can see 95 caregivers have agreed to participate. The primary endpoint has changed from household financial hardship to household financial hardship. And the Patient Advocate Foundation is now the sole provider of the counseling. So again, based on feedback from all of you, really, really nuanced and changed this study so that it's much more feasible, and we can see those results within what we're seeing for accrual. I would like to highlight the recent visit by Dr. Jill Biden, the First Lady, to the Fred Hutchinson Cancer Institute, which was it was 2 weeks ago now, because I sent my slides in last week. And Dr. Shankaran, who is the PI of the credit study, was one of the panel members who met with Dr. Biden, and she did a terrific job talking about financial hardship and actually mentioned the credit study, not credit by name, but said we're doing a study within a large network, and discusses it. So there is a link here within the slides, which Monica can share with you. And it's a short little video to watch, and it's really nice. Please feel free to take it back and show your teams all the work that they're doing. Here's some additional studies that we have open right now. I'm not going to go through all of them step by step, but the Wake Forest HN STAR trial, we have the SHARE studies from the Alliance. We have a children's oncology group study, which is looking at financial hardship as well. And this is focused on the parent of a child who is receiving leukemia treatment. And I will tell you that I think that study is going to be closing here within a week or two, because it's only got 2 patients left to accrue. We have 2 additional studies from Wake Forest Rochester, the University of Rochester. One focused on oncology drug shortages. Needless to say, this is a very, very important topic right now. So they have just amended this protocol to allow practices that completed data collection early on to now re-enroll and complete 1 additional quarter of data submission to try and capture some additional drug shortage data. And then we have the University of Rochester Enable study, which has also undergone some major amendments to make the study workload much less and have rolling admissions. So a lot more flexibility in this study. We have a lot of protocols that are soon coming down the pike. We have 6 protocols that we are expecting to be opening in this funding year. I can tell you that the top one, the EAQ 221 CD, is already approved by the Central IRB, and it's awaiting activation at ECOG Akron. And then the second one from the bottom, the Wake Forest 2300 CD, that has also just been approved, and I think will be activating quite soon. And the rest are in various phases of at the IRB to soon going to the IRB. So lots of protocols coming out in the next 6 months from Cancer Care Delivery. I wanted to close by just giving a couple of quick updates on the system level because we have made a couple of changes. And I think the first one, everybody in the room who's familiar with this is going to cheer and be happy about it. So we had a requirement for the last 4 years that there needed to be a practice level survey. It was a 6-question survey that had to be on file with CTSU. It asked about the number of analytic cases you had, whether you were a federally qualified health center, those sorts of questions. And that had to be on file in order for you to participate in a CCDR study. We are happy to say we've collected all the data that we need from the organizations there. And so as of last week, we are no longer requiring that this practice level survey data be on file, and that will be removed from the protocols by amendments as we move through. But CTSU will no longer be making that a requirement. And then we also have a new capacity in the open network where we can link more providers across your sub-affiliates. So if you have a provider that goes to 3 locations or 4 locations, that provider can now be linked better within the open network. So it actually helps the research base because the research base was doing all this work on the backside to kind of work around that. And we now have that capacity. So with that, I just want to express our thanks from the entire team at NCI and the NCORP for all of the work that all of you do to make these studies possible. And I'll be happy to take any questions for the 3 seconds I have left. I don't see any. All right. Thanks, Monica.
Thank you, Kate, for your presentation and your updates on CCDR. Our next presenter is someone you may be familiar with, as his SWOG research publications, such as Quantifying Years Lives Saved by Federally Sponsored Trials and publications on socioeconomics and access to care and cancer disparities have made headlines. It's my pleasure to introduce Joe Unger, the Statistics and Data Management Center's NCORP Vice Chair, who always has the longest presentation titles, the Affordable Care Act, Medicaid expansion, and enrollment of patients with Medicaid insurance to cancer clinical trials. And I took up 3 minutes of your presentation already.
Good one. I have a pointer. So you'll have to forgive me. I wrote this last night between 10 and 1:30 a.m. And I spent most of that time finding a picture of my kids. So I'm always happy to come back and show you guys another picture of my kids, the annual photo. This is at the Oregon coast about a month and a half ago. For those of you who've been to the Oregon coast, you know that summer in the Oregon coast is more like, it's not too distinguishable from winter, but with this 50-degree water and 60-degree temperatures. But that didn't stop my kids. So we didn't just go in the water once. Okay, we went in twice a day for a week, and it was cold, but we got used to it. Anyway, on to the talk. Sorry for the long title. There's a lot to consider. And so I'm going to kind of walk through this, and you bear with me if you could. It's kind of a complicated analysis, but it's sort of necessary to get at the answer, I think. So we're focus here is on the ACA and cancer clinical trial participation. We know that the passage of the Affordable Care Act led to tremendous changes at the population level in whether and how patients obtain insurance. One key feature of the ACA was the expansion of Medicaid eligibility for individuals earning up to 138% of the federal poverty level. And individual states could choose to adopt the measure or not. And many did, but not all. So the Medicaid expansion resulted in increased use of Medicaid insurance nationwide, including for patients with cancer at the cancer population level. But the association between the Medicaid expansion and access to clinical trials had not been previously examined. And it's kind of a hard question to answer. But it's important both for patient access, of course, and because the nature of clinical trial cohorts is going to affect both their results and their interpretation. So we examined the number and proportion of patients insured by Medicaid at enrollment over time using data from the SWOG Cancer Research Network. We examined all patients 18 to 64 years old. So this is a younger patient, for want of a better term, issue about Medicaid participation, who were enrolled to treatment trials between April 1992, which was when SWOG began to enroll, systematically collect insurance data, until February 2020. You notice the cutoff is just prior to the pandemic onset, because the pandemic was not representative necessarily, or at least we wanted to get a sense of this relationship pre-pandemic, I guess is the better way to say it, before things got all interesting, to say the least. So it wasn't considered representative. So we just went through February 2020. We also used national unemployment data from the Bureau of Labor Statistics, because it turns out that there is a very important relationship between enrollment to clinical trials and what's going on in terms of socioeconomic status in the population. And our focus was just on Medicaid versus private insurance. So we excluded some other insurance groups. We used an interrupted time series analysis with what was called segmented binomial logistic regression. So a patient either had Medicaid insurance or they had private insurance. The implementation of the ACA Medicaid expansion, which started in 2014, was the independent exposure variable. And to account for the secular trends that were observed in Medicaid use related to economic conditions, we adjusted for the monthly unemployment rate using those data from the BLS. So in total, we had 51,751 patients who were less than 65 years and were analyzed. I just want to draw, as a digression, draw attention to that number. That's a large number. That's more than 50,000 patients whose efforts contributed to this analysis, which is pretty incredible if you step back and think about it. Patients were predominantly, 2/3 of them were female. I think a lot of that is younger breast cancer enrollees. 8.4% were Black, and about 60% were from states that implemented the Medicaid expansion in 2014 and 2015. So here's the figures I want to walk through. I do have a pointer, right?
Yes.
Oh, there. Okay. Where is it? Oh, is it on? Huh? Am I pointing at the screen then, or? Oh, that's not going to work.
I know.
Maybe. Okay. So before the implementation of the Medicaid expansion in 2014, what we had to do first was get a sense of what is going on. This is like the baseline period, because we're going to be modeling the period forward in time, after 2014, based on what's going on before then, right? So before the implementation of the Medicaid expansion, the proportion of trial patients using Medicaid, which is shown in these dots, monthly dots, the dark dots above, with a smoothed regression line through those dark dots, okay, showing general sort of average trends, basically paralleled the national unemployment rate. This is a really important thing to recognize. In fact, the trends are highlighted during recessions. So we had the recession in 1990 to 1991, the dot-com bubble in 2000 through 2003, and the Great Recession of 2009 2007 to 2009. In each of those instances, the unemployment rate goes up, of course, during these recessions, and you can see it going up. Additionally, the proportion of patients in SWOG trials who are using Medicaid insurance is also going up. But there's about a 1-year time lag between the peak or nadir of the unemployment rate and the peak or nadir of the Medicaid use in trials. In fact, can I go back? It's quite regular. You can see that, for instance, the peak of the unemployment rate for the .com bubble occurs about 11 months before the peak of the use of Medicaid insurance in SWOG trials. For the Great Recession, it's about 13 months. These numbers are all fairly similar. It's about a year. And in fact, if you account for this time lag and then represent these smooth regression lines on similar scales, the curves representing the national unemployment rate and Medicaid use in trials are nearly superimposable. I think this is a really important observation, independent of the main finding of this analysis, because it says that socioeconomic conditions in the population are affecting who goes on to clinical trials. So this pattern of parallel trajectories in Medicaid use and the US unemployment rate was then interrupted by the implementation of the ACA Medicaid expansion. So you can see all these states adopted the ACA Medicaid expansion. And whereas before these lines were tracking together, after that, they started to diverge. In fact, beginning in 2014 and 15, there were 31 states that adopted that Medicaid expansion. And the proportion of individuals in trials who use Medicaid, as you can see, began to increase, whereas it continued, the unemployment rate was still decreasing because the economy was good. And so when we model this, put all this together and model what we expected to happen, what we expected to happen based on economic conditions in the cancer in the population. We expected, because the economic conditions were still good and the unemployment rate was going down, what we should have seen is the proportion of patients with Medicaid insurance in trials going down like that. But what we actually observed was it increasing. Okay, this is sort of the basis of the modeling to answer this question. And in fact, overall, there was a 19% increase per year in the odds of patients using Medicaid after the implementation of the ACA Medicaid expansion. The model-based estimate at the end of the study period, that is February 2020, was 6.9% when national unemployment was low. That's what we would have expected in the absence of the ACA Medicaid expansion. But what we actually saw was a rate in February 2020 of 17.8% among these individuals less than 65 years old. And it doesn't just translate to proportions. We also found there were 970 patients with Medicaid insurance enrolled over that 2014 to 2020 period, but we would have expected 640, which is a 52% increase. So in summary, the ACA Medicaid expansion was associated with nearly 3 times increase in the proportion of patients using Medicaid in SWOG trials by 2020, which was much more in line with US cancer population rate, not population, cancer population rate, which is estimated at 17.6% in 2020. So what are the implications of this? Well, as I mentioned, which was apparent from looking at those figures, the socio-demographic composition of clinical trial cohorts is very variable over time. It wasn't a flat line. It was going up and down. You could see those waves. But it was tracking with the unemployment rate, which is essentially a surrogate for the socioeconomic status conditions of the country. And I think it's really important to realize and take away that the composition of clinical trials really needs to be recognized to be in part the sort of organic manifestation of extant socioeconomic conditions. It's not a static population. It really depends on what's going on in the world. Moreover, it's important to realize that targeted policies like the ACA Medicaid expansion can act to counterbalance the potential adverse consequences of these societal influences on trial composition. So we conclude from this, improved access to clinical trials for Medicaid patients, of course, provides greater access to the newest treatments in trials for socioeconomically vulnerable patients. I think that's point one. It's also critical for improving confidence that trial findings apply to all patients. Is also important for improving enrollment so that new drug discoveries can come faster. There was a recently enacted Cancer Treatment Act, which is in 2022, which mandates that the states actually provide a coverage for clinical trial participation for serious diseases at the state level. So it remains to be seen, what impact that has. But hopefully it continues to improve access for Medicaid insured patients. And I just want to thank, first of all, of course, the many thousands of patients who contributed to the research, to their caregivers, their providers. Like I said, more than 50,000 lives go into this particular analysis. I want to thank my collaborators, as shown above, and also the funding from the NCI and the American Cancer Society and the Hope Foundation. Thank you. Despite the long title, I went too quickly. There's 10 minutes left to grill me. So, any questions? Okay, thank you.
We are very pleased to welcome Dr. Barbara Segarra-Vazquez, professor at the University of Puerto Rico School of Health Professions, who is also the incoming co-chair of the SWOG Patient Advocates Committee. Barbara will provide the trial participant perspective in Timing is Everything.
Good afternoon, everyone, and thank you for the invitation. Everybody knows I never can say no, so I always say yes, and especially when Monica wrote to me. So I'm happy to be here. And so we're just going to discuss, describe the participants, what patient advocates do here at SWOG. I don't have to explain what CancerCare is because Kate did that for me, so I have more time for other things. We're going to discuss strategies to approach patients and describe the importance of all of you guys as staff in the sites. So in terms of SWOG was kind of the leader of including patients' voice. And I wanted to share so you know that before all these concepts protocols go to you, patients have been involved from the concept on. And so SWOG started in 93, was the first group of invited patient advocates. And in 94, they created the group. And by 97, it was a pilot program and it was received by NCI. And advocates are now permanent partners at SWOG. And it was the first NCI group to formally involve patients in trials. And in 2019, we started a new concept about community advocates that we're still working on. And this map is from NCI is how patients could be involved, and it's not it should not be an afterthought. It's from, again, we can help with providing possible ideas to how it will work or not, and I'll give it specific examples. I forgot to mention I'm also the patient advocate for the cancer care delivery. So in the 6 years I have been in SWOG, I have learned a lot about clinical trials and about cancer care delivery. And NCI also established how important it is to involve patients and patient advocates. And in breast, for example, we have been a two-time breast cancer survivor, so we have advanced this a lot. Breast cancer advocates have been out there in the Hill and in different things all the time. And now other groups that maybe are rare disease or things are doing the same because we need that patient voice, right? And it has proved that improves clinical trial research feasibility. It improves accrual and retention, increases public trust. We can help other people understand what trials are. Helps other advocates understand effectively and communicate about science. And we can assist in disseminating that information that it goes, we have the publication that goes to scientists, but we have to deliver that same message to patients. And I wanted to share one of our patient advocates. Her name is called Laura. And she did the full circle because when she was 28 years old, she was diagnosed with kidney cancer stage 4. And she started with a back pain, and all of a sudden she had 2 kids, and now she had stage 4, and then it metastasized to the liver, the lymph nodes, and the lungs. And so she was referred to doctor, and I'm sorry if I abbreviate his last name because I cannot Wolgenstein. And so he was participating in a trial S1-500. And she was offered that trial, and she participated. And 3 months later, he came and he said 80%, and she's like, 80% what? And he said 80% responded. You was eliminated from your tumors and things like that. So in 3 months, she had no evidence of disease. And in 2022, when the doctor died, her physician. And she was mourning that she had applied for a SWOG position to be in the kidney disease committee, and she received a call to be interviewed. And she's now part of our patient advocates. And when she came to the first meeting, the scientist that came up with the idea of the trial was there, and they hug and whatever. So this is what happens, right? That you see the first circle, and now she's there giving her testimony and really engaging others. So science does happen, and it helps us live longer. So this was about cancer care delivery research that Kate saved me time. But when I was preparing for this, I find an article it's a study from the Hawaii Cancer Center and NCORP. And it wasn't a formal study, but they were doing clinical coordinating services study in their site, and they interview and did focus group for patients and family members. And what they found, because sometimes we think that patients won't want to participate, and one of his conclusions was overall patients perceive many positive aspects of CCDR participation and express enthusiasm about participating in these studies. And some of the things he mentions in the paper that was wrote, it was a commentary. He says, like, in terms of motivation, most of them did it based on altruism, right, helping other people that might be in their shoes. And they also said, I hope doctors get to listen to what is happening. And they felt even more engaged with their physician or practice, knowing that they were participating in these trials, because they sense it like the practice care if they're asking me about all these things. And so even if we think it's not important, it is. And he says that some of the patients that participated in the focus group or they were calling back, they need me for something else, I want to participate. So it goes to sometimes we underestimate what a patient wants to do, and we just have to listen. But the most important thing is you guys are where the magic happens, right? You make the magic happen. You are the link between the research and the patient. And your input is important throughout the research cycle, right? Cancer care studies are very important, and as we live longer as patients, we need to know, and we need to the service to be delivered better, right? And that's what we're looking for. And another thing I wanted to mention, when to ask a person to participate, right? And these could be even from drugs trials to cancer care delivery studies. When you're diagnosed with cancer, that's another whole world. Just understanding what is your disease, what type of disease you have, what treatment are you going to be given. And on top of that, they talk about a clinical trial is too much, right? Because as cancer, I am a scientist, I'm a medical technologist. I have been working at the medical sciences for many years when I was diagnosed. And when I heard the word cancer, it was like going to first grade for the first time again, right? So I needed to understand, what's the breast, where's the tumor, what's going to happen, what are the lymph nodes, what are the chemo. So if you're just diagnosed and then, oh, by the way, you want to participate, that's maybe not the best time. It's also, part of what we don't do a lot for are the caregivers and the family members. We as patients, I tell, we know what we're doing. We're taking our treatments, but family members are the one carrying us, all through it. So it's important that if you're going to talk about a trial, invite the family member, because I remember when I was diagnosed, I kind of was in a blur, and my husband was, okay, they told us A, B, Z. He memorized everything that they told us because his mind was for that, right? Give the person time to understand and ask questions. Participating in a trial is not lightly, right? In whatever trial it is. And a 5 minute, half an hour, or an hour conversation is not enough. So if you can give them the consent, let them read it calmly in their home, discuss it with their family member, and then maybe have somebody to answer their question. And let the person take them for, okay, yeah, that's what I mentioned. That's why I said, Monica, I want to call this timing is everything, right? And I'm going to give you 3 examples, at least 2 of that very bad timing. When I was first said I had a mammogram and I said, yeah, I had a suspicious lesion. I went to a surgeon. This guy went, okay, yeah, I'm going to do surgery on Wednesday. And I said, but doctor, is this benign? Yeah, it's usually malignant, but he left the office. And then this girl comes with a clipboard. And so he said he's going to have surgery December 15. And do you want to participate in a trial? I said, no, girl, I'm not taken care of by your doctor, and I'm not participating in your trial. I'm just heard I might have cancer, or possibly high chance that I have cancer. So that wasn't the best time to really approach if I didn't even know what type of cancer I had. And by the way, when you're in surgery, you're going to participate in a trial. No, it doesn't work. The second one was a couple of years ago. I went into a colonoscopy study. And I know the person, she's a researcher, she's a colleague that works with me at the University of Puerto Rico. And when I'm naked in my gown, going to a colonoscopy, which whoever has gone there knows it's not a fun thing to do. And you're like all stressed out. And then this Chris, I'm sorry, we're going to be participating in a trial. And do you want to participate? And I look at her and I said, sure, because I know the researcher, I know what she's doing. And when I was out, I told her, I told the PI, you can't do this to patients, right? You can't approach them while they're going to go on the first set, or maybe even after a set, you never know what they're doing there. So, timing is everything. And it's important to take the time and see what are the circumstances that these patients are going through. And then for the follow-up or the FUP, like we heard previously, not only because participating in a trial, I think there's in most of the trials that can you be contacted again? Again, I'm a scientist. I work with SWOG. I know about participating in clinical trials, but the general people don't know. And maybe it was 15 years ago that they didn't even remember what they did. So give them a little background and say, how important it is to participate in that. Important about giving feedback. You are, as staff, the eyes and ears of the research study. Let us know about your concerns because we can change it. Kate mentioned it and Dawn mentioned it, and maybe because I told her last night, she kind of remembered and gave it away today. But the part about credit, I'm a patient advocate for credit since they started with this concept with Vina. And when talking about, for example, the couple being married, and one of the first amendment, I was going to talk, it was a kickoff that we were going to do for credit. And I usually, when I give a talk, we have a network of advocates of different disease and whatever, and we share, what should I say, right? Because I cannot speak for myself. I want to learn from others. And I said, this is a trial, and you have to be married. Who gets married these days? That's not going to work and whatever. So the First Amendment was like, don't require people to be married. And I have two sons, and logically they're not married, right? So I know what she's talking about. So we did those changes. And Kate explained the other changes, amendments that we did, but it was because you were there asking that. Another one was an example, 1912, that we also did talk to sites, and they were saying, you know what, they don't cover both CA 15.3 and CA 27.3. Some insurance don't because they consider it's the same. So the court from SWOG was sent all the guidelines, but it was, and I think if they finally said it could be either or. But if you don't inform the PI, we don't know that is what's keeping patient from recruiting. So my message is, you guys make the magic happen, and you guys have to let us know. And sometimes in patient advocate committee, we sit our disease committee, and we also have a committee among ourselves. And sometimes I hear people, they say, well, we cannot do anything about the sites. Well, maybe we can do. And this morning we had kind of a brainstorming and said, maybe we should bring a patient navigator from a site and talk to us. What are the challenges? So we learn, right? Because we talk from our perspective as patients, but you guys are in the ground, so you can tell us what really happens. The other day I was in an NCI planning meeting, and we were talking about assessing for transportation or housing and things like that. And they were saying, well, if we don't have, we can provide support, why should we ask? But then again, somebody gave an example that just by asking if they had transportation problems, help them space the treatment. Instead of 2 weeks, they did it 3, and the time and things like that. But if you don't ask, you don't know, right? So it's important about that. I just have 2 others in terms of, as a Latina, I'm always trying to increase awareness of diversity in clinical trials. And I remember when I first sat at the PAC meeting, my first question back 6 years ago was, how many Hispanics have been impacted by the studies done in SWOG, right? Now we have a dashboard, now we have, but just being from, and it's not on purpose, right? But that's the beauty of having diversity, because I'm going to think about that because it's my community and I want to learn more and I want to be impactful in that part. So ASCO did a white paper called Increasing Racial and Ethnic Diversity in Clinical Trials. It was a joint between ASCO and AACR, and they had a patient advisory board. And I was blessed enough to be part of that. So it's there. And they also have 2 resources that are for free, that they, as a site, you can evaluate, do a self-assessment, and there's other research. So they are both for free that you can assess as a site, right? So in conclusions, SWOG includes patient in the whole cycle of clinical trials, and we should also include you guys. So every time you have an idea, a worry or thing, please share it with us. Site staff are important key players in the implementation, recruitment, and retention of participants. You make the magic happen. Timing is everything. I hope you remember the GON and the colonoscopy. When and how possible participants can be approached makes a huge difference. Site feedback is important. Patients are willing and able to participate in research, just ask. And Dr. Unger did a study on that as well. As we always assume that minorities don't want to participate, but literature shows that they're just not invited, right? Or we assume. So part of my message is, don't assume that someone does not want to participate. For example, when we were discussing credit, we were saying maybe they have to make sure that they know we're offering it to everybody. It's not that they saw me that I'm Latina, I'm going to be poor, and that's why they're asking me. So we assure that. And don't, and even if they are not the intervention arm, there's a lot of materials that we review before the credit that when I was reviewing, I learned how to read the insurance bill that I never knew before, right? Many years after it. So it's important. And the way you approach and explain to patients, it will make a difference if they want to participate or not. And for me, right, thanks to science, I will celebrate 20 years, December 15 this year. And to the left, that was just when I had my lumpectomy the first time, and my kids were 15 and 10. They are both medical engineers. And 2 years ago, I'm giving my age away. I celebrated my 60th birthday with my two handsome boys. And it's all about science, right? And what we do and what you do is to make us live longer. I'm still not an abuela, so my kids are, I don't know what they're doing, that they don't want to have a kid. So I tell them, I might have to adopt a grandchild, right? So who knows? But anyways, it's important what you do. And for us as patients, I'm grateful to the scientists and especially to all of you that do the work. Thank you. Any questions or comments? Here. You're welcome.
All right, thank you, Barbara, and thank you to everybody for joining us today. Just a few housekeeping items before we move on to our breakout sessions. I want to thank you for being with us for the last 2 hours. We still have a nice afternoon planned ahead of us. We have now I get to do this. And I don't think I introduced myself before. I'm Monica Yee, I'm Program Director for Data Management for the NCORP trials in Seattle. All right, so our theme today is building a foundation for our breakout session Q&A session. So there's going to be 4 rooms. You just take the escalator upstairs the agenda should have all the room names on there. So I'm not going to go through those right now, but the first one is going to be about trial management, feasibility, implementation, and maintenance, navigating a SWOG protocol, forms follow function, and then finally with Yvonne and Ashley, let's talk about participant follow-up. Each breakout session is 25 minutes long. There'll be 5 minutes in between to switch at. And then for our virtual attendees, we also thank them for joining us today. We're going to try this out and have a virtual component as well. So the Zoom links and the handouts are all available on the website for the virtual website for the SWOG group meeting. And this is a different view of it because all of us see things differently. One other thing I would like to really focus on is that there's another great opportunity at 3:30 this afternoon after the breakout sessions with our recruitment and retention committee, a really great follow-up to the discussion that we're going to be having in breakout sessions about community engagement in clinical research and how to enhance that at your sites. So they'll be discussing underrepresented populations as well as the digital and practical approaches. So please be sure to join that. They have a great panel of presenters this afternoon. Next year, I can't believe this is going to be our 10th annual workshop in the fall. So we hope to see you there. And once again, thank you so much for all the work you do with us in addressing the health disparities and cancer clinical research for our participants. And I think there might be some food left still right now. So grab a beverage and please run upstairs. And we thank you very much for coming today.